Hello again, everybody, and welcome to another edition of Health Center. I'm Lorraine Brooks, and I will be your host for today's show. Today we're going to be talking about a very serious topic. The topic is suicide and suicide prevention. There are a lot of misconceptions about suicide, a lot of misconceptions about people who attempt suicide, people who speak of suicide, people who have completed suicide attempts, and people who have not completed suicide attempts. And there have been some events in the news lately about medical students who have been in trouble, and a couple of medical students recently who committed suicide. And as a result of that, we here at Downstate, because we are also a medical school and we do train doctors and healthcare professionals, we're very concerned with some of the things that might contribute to someone's feeling despondent and depressed and in a position where they think that suicide might be a viable option. So today we're going to be talking about how to prevent suicide, what to look for, what are some of the risk factors, how you can help somebody that you feel may be in trouble. And my guest today to speak about this is Dr. Joseph Merlino, who is the Vice President for Faculty Affairs and Community Professional Development, Vice President for Faculty Affairs and Professional Development here at Downstate Medical Center. And he's also Professor of Psychiatry and Public Health. And he's been recently named an ambassador at the New York Academy of Medicine, and we're very proud of him for that achievement. And I'm very proud to have you on the show today, if I may call you Joe. Sure. That's how we usually refer to people here. I'm very happy to have you on the show today. This is a very important topic, and I think that it's very often misunderstood, as you well know. So why don't we start with, I did a little bit of research and I found some statistics, and I just might want to mention them so that the viewing audience has some idea of the magnitude of the problem or the seriousness of the problem. The Substance Abuse and Mental Health Services Administration recently did a survey in 2015, and as a result of that survey, they found that 4% of Americans over the age of 18 had thought about killing themselves in the previous 12 months. Now, that doesn't sound like a lot, 4%, but to me, that's very alarming. 4% is a lot of people.
Absolutely.
And also, it said that 42,000 people in the United States die from suicide every year.
Right.
And that suicide has now become the 10th highest cause of death in the United States.
That's right.
That to me is very alarming.
Yeah, it's actually 1 million worldwide take their lives each year. And as you mentioned, almost 43,000 people in this country. That's like 117 people a day. And if you think about, we are at a medical school, that's about the average maybe 2 to 3 medical school classes a year.
Okay.
Take their lives in terms of physicians alone.
Wow.
So between 300 and 400 doctors take their own lives a year, and about, as you mentioned, almost 43,000 Americans.
So do you think there's any, excuse me, do you think there's any correlation between what you do for a living and your risk factor for committing suicide? You mentioned physicians. Are physicians necessarily more prone?
Unfortunately, yes.
What makes them more prone, do you think?
Well, burnout, which is something that's epidemic in the medical profession right now. In fact, of American physicians, about 50% or more report themselves as having serious signs or symptoms of burnout, and burnout is one of the risk factors for suicide.
So let's talk a little bit about burnout. What exactly is burnout? How do you know if you're burned out?
Well, it is one of those things that you kind of do know when you're burned out. I like to think of it as the snuffing out of the flame of altruism and the passion of the calling of medicine. And medical students know that, and doctors can remember back to when did they want to be a doctor. They know what that energy and enthusiasm is like. And they also know what it's like to blow out a candle. And when they feel that passion is blown out, they're burned out.
That can also apply, obviously, to other professions as well, right? I mean,
It does. It does apply to other professions as well. Usually professions that are in high-risk kinds of jobs that are very demanding. Police
I know,
force,
right,
education,
exactly. People
for
who
example,
see a lot
airline
of negative.
pilots, first responders. But it is
Why airline pilots?
I think the stress and the responsibility that they have. You know, and the other thing that leads to burnout are a sense of powerlessness and a sort of loss of autonomy. And when you think about it in terms of the medical profession, that is something that has increasingly been happening over the past many years. The more doctors are no longer in private practice, where they were kind of their own boss and ran their own day and did what they wanted to do and practiced in the way that they wanted to practice.
So the landscape of practicing medicine has changed.
Has totally changed.
Tremendously.
More people now, more doctors now are working for large organizations. The pressures that are in large organizations are more focused on the 7-minute medical encounter rather than how Dr. Kildare or Dr. Ben Casey or those doctors sort of practiced on TV many years ago. And the autonomy has been lost, where doctors are spending more time in front of a computer screen, typing into an electronic medical record that is asking more and more questions that take them away from actually wanting to have contact with a patient.
And you know, that's true. That's not only true of medicine. I mean, isn't that true of our society in general? That we've lost the personal touch with people. Yeah. A lot of, there are jokes about it, but it's really true. People get together over dinner and everyone's going like this and no one is really speaking to each other or finding out how each other are feeling or how you doing, or, you know, it's just a vague kind of encounter that we have with most people. And so it's not just medicine, it's all of us.
Right.
We don't talk.
Right.
We don't talk, we don't interact,
right.
we don't have time.
But the important thing is the example that you're using. For example, our millennials are very, very high-tech young adults. And
millennials being people who were born since the turn of the century. I can't believe I'm saying that. Since the turn of the millennium.
There are people that are in their 20s today. Usually people that are in our medical school classes and in our colleges are millennials. But even though they might not be talking one-on-one with a person face-to-face, they still have human contact, even though it's through social
electronic
media.
means, right.
So the important thing with suicide prevention is making sure people are still connected in some way and not losing that sense of connectedness.
So what are some of the, you're mentioning connectedness, and I know that depression, isolation is one of the things that might be a risk factor. Would you talk about some of the things that might be risk factors, for example, isolation or feeling disconnected or feeling helpless or feeling like there's no hope?
Sure. Well, those are all excellent examples of it. But in general, it's when somebody has a loss of meaning or a loss of purpose. And I like to think of it that way. I remember as a resident in psychiatry having a supervisor who always said, if you could find a person that has a purpose in life and a sense of meaning, it's highly unlikely that that person is going to be suicidal. And my experience has borne that out. I mean, Viktor Frankl is a perfect example during the Holocaust of a person that kept himself alive because he never gave up on a sense of purpose. So that's one of the things that if you're looking at a friend or a family member or a colleague and you get the sense that that person no longer has purpose or talks about no longer having a purpose in life, no longer having a meaning in life.
Well, you know, if I can interrupt you for just a second, a lot of what I've read speaks about young people being vulnerable to suicide attempts. And what you just said to me would sound like that would be more of an older person's issue. Yeah. You know, as people age, they might, as they give up their careers and their friends and family are dying out, that might be more of an older life kind of scenario. Yeah. But that's not what happens. It's a lot of young people that are feeling that way, you know?
Actually, statistically, the highest risk age group was the older age group. It's only the latest data, which I think is 2015.
That's very recent.
That's come out, has shown that the highest age group that's at risk now is 45 to 65.
So what happened?
So it's middle age.
Okay.
It's middle age now. And the other interesting finding, and this was, I believe, just released in September of 2016 by the New York City Health Department. In New York City, the suicide rate has been constantly going down during the 1990s, which is a good sign. But since the year 2000, it's steadily going up. So the suicide rate in New York, even though it's half the nation, has actually been going up over the last 16 years.
Do we have any idea why that is?
I haven't seen it spelled out as to why, but knowing what some of the risk factors are, I think we can intuit that part of it has to do, again, with a loss of meaning and the fiscal environment that people are in. If you're going to lose a job, or you're going to lose your home, or you're going to have a relationship breakup, these are all risk factors for suicide.
So most of those things have happened to all of us. Most of us have had relationships not work out. Most of us have lost jobs or changed jobs that,
Right.
When we maybe didn't want to because of necessity. Most of us have had financial issues.
Sure.
So what is the difference between somebody who experiences those things and doesn't have suicidal thoughts and somebody who experiences those things? How do you know what you're looking at? In other words, if you're a family member of mine and I know that you've been through something recently, but I'm not necessarily expecting you to not be able to handle
Right.
that. So how would I know? What would I see, or what might be some of the things you might be saying or doing?
That's an excellent question, Lorraine. And if you think about it, what causes suicide in an individual is so variable, and it really depends on what the individual's resiliency is, what an individual's ability to spring back from adversity is. And we all know people that have, like that punching doll, you knock them down and they get right back up again.
Yeah.
Those people seem to have limitless resourcefulness, and those are people that are in a good place. There are other people that the accumulation of stress sort of tips the balance, where their resiliency can't match the stress that they're having, and those are the people that tip into that area that we need to be concerned about. And these are people who might start talking more about no longer having meaning in life, feeling that they're no longer effective at what they're doing, that feel they just don't have hope, they don't want to go on anymore. When you hear someone starting to talk like that, that's a warning sign that you really need to take seriously.
And what should we do if we hear something like that?
Well, we need to be brave enough to recognize that the worst thing that can happen is the person saying to you, "That's a terrible thing to ask me. No, I don't feel that way." And that's not such a terrible thing when you actually think about it on balance, because if that person is having thoughts about taking their life, they're going to find that a welcome, although difficult, discussion to have with you, and you might actually be saving a life by asking, because what you're doing is you're showing that you care, and that person who might be feeling no longer having an impact on other people and no longer having a place in this world might start to think differently because of the compassion you're showing to her or him.
So we shouldn't be afraid to approach the subject with people.
Absolutely
I think
not.
a lot of people don't want, we sort of keep our heads in the sand, and I think a lot of people feel like some things are better not said,
Right.
or if I bring it up, I might give them an idea, or I
Right.
might,
You're gonna
put
put
an
a thought
idea in their head.
Right.
Exactly. And I've heard a lot of people say that too. Well, I heard, Mary say such and such, but I didn't want to pursue it because I didn't want to give it any energy, or I didn't want to, make an
Right.
issue out of it. But you're saying exactly the opposite,
That's
that if
right.
you hear people say things like that, if you see something, say something.
It's
Remember
exactly
that? Yeah,
right, and it's applicable to suicide prevention as well. It's a widely held misconception that if I suggest, "Are you thinking about hurting yourself?" that you're going to put a thought where the thought doesn't exist.
That I might say, oh, I wasn't until you said that, but now.
Quite the contrary.
Okay.
And the other thing is, people have this belief that if I talk about it and a person wants to take their life, they're not going to talk about it. The opposite is true. They're looking to talk about it.
Oh, okay.
Suicide, many people, the other misconception is that this sort of comes out of the blue and there are no warning signs. Most people that commit suicide have seen a healthcare provider within the previous few months. So
are we not asking the right questions? Are we not
that's part of it too.
pursuing?
That's part of it too, because again, when you think about what used to be the medical encounter and you had a lot of time with your doctor, to now having 7 minutes where you're playing beat the clock to get it in and get out, a doctor might not ask a really critical question because it might seem frivolous.
And you know, I actually had that personal experience.
Of course.
I was having an issue some years ago. I don't even remember what the issue was now, but I mentioned to my GP, my general practitioner,
Right.
you know, I'm feeling kind of whatever it is about whatever, and she said to me, I'm not your therapist.
Yeah.
You know?
Right.
And that took me back. Of course, I know you're not my therapist, but gee, you know, how long have you known me that we can't have a dialogue about something that's going on in my life that may, in fact, be affecting my health in some way?
Of course.
Right?
In fact, that's a risk factor for suicide.
And there you go.
Sorry.
Sure.
That is a risk factor for suicide. Somebody that has
Okay. Change in health status or something?
change in health status or chronicity, somebody that has a chronic medical illness, that again, that resiliency is just starting to give out, or mental illness. Depression is clearly one of the biggest risk factors.
So
for
how do you,
suicide.
I'm glad you said that, because depression, I think, is a kind of a buzzword. How do you assess for depression? What kinds of things would, I mean, you're a psychiatrist, so you
Right.
do it in a clinical way. But the average person, how would we know when a friend of ours or a family member was exhibiting signs of depression? And depression is an illness. It's not just somebody being unhappy, right? I mean, a lot of people think that.
That's right. And all of us have days where we're unhappy or sad. And you mentioned before that all of us have events in our life that upset us and make us sad. Loss of job, loss of spouse, death, etc. When you need to get concerned is when it's persistent, and when the symptoms are increasing, when the sadness is getting worse, when it's starting to actually impact how a person is getting along with others or how a person is doing at work or with family or friends. If they're not getting out, if they're staying home all the time, if they're staying in bed all the time, if they're losing weight, they're not eating, they're looking slovenly, they're just not taking, they used to look beautiful and sharp, and all of a sudden they're starting to look a little bit messy and unkempt. When you see those kinds of changes, it has to raise, you know, a signal that something's going on here, and what's really important is to ask.
So over time, you observe a person and you know that person to be a particular way, and then you notice a change, a negative sort of change.
Right.
That would be something to pursue, something to look at.
That's right.
You know, my job here was director of the Employee Assistance Program.
Yes.
And what you just said is very important, because a lot of times the workplace is somewhere where we do begin to notice changes in people.
That's right.
And exactly what you said. People's personal appearance may start to suffer, their hygiene may start to suffer, they're not concentrating on their jobs, they're making mistakes, they're not paying attention to things that they used to pay attention to. And so the workplace can be a very supportive and positive place to start to deal with some of those changes. And that's one of the things that we were trying to point out here at Downstate, that when people come to work, and I think we have a misconception as well, that when people are working or they're able to go to work, that means everything is okay.
Right.
And that's not always the case either. Sometimes people come to work just out of habit or because they want to have some continuity.
Sure.
But it doesn't mean that everything is okay just because you're working, you're
That's
not
right.
functioning.
That's
You're
right.
you're there in body,
Right.
but you're really
But
not
you're
there
absent everywhere
in
else.
spirit or in soul. Yeah.
And you make an excellent point that, you know, we spend more hours in the workplace than we
yes.
probably do anywhere else.
With our family, sure.
So there's a lot of folks that might be able to see that something is changing. And that change in an individual might not mean that they're suicidal. It could be any number of things, from, you know, depression, a medical condition, early onset dementia. Who knows? It could be a lot of things. But it does warrant not disciplinary action,
Right.
but a supportive, you know, supervisor or supportive colleague to say, you know, I've noticed there's a change. How can I help? What can we do?
And you just said something really, really important, and I want to reiterate it, because I think that's one of the take-home messages that I think we would like to convey, is that it's okay to not be okay.
That's right.
And it's okay to ask someone if they're okay, and it's all right to talk about not being okay. I think we have this, I don't know where we get it from, maybe it's, you know, the kind of stoic American psyche, I don't know what it is, but we have this feeling that we always have to be okay,
That's
and
right.
that even if we're not okay, we have to sort of act as if we're okay
Right.
and pretend that we're okay in order to save face or whatever.
Right, and particularly in a place like New York, where everybody is most people are driven.
Right.
You can't even walk on the street anymore. You have to look left and right on the sidewalk, but you're not going to get trampled by somebody rushing behind you. And in our particular environment here at SUNY Downstate, we're dealing with perfectionistic types, people that want to go into research, science discovery, medicine, healthcare. They're all perfect. You can't admit that you might have a need or you might be less than perfect, because that's going to damage your career. And that's one of the things we're trying to do now with the wellness program for physicians and healthcare providers. Male physicians have a suicide rate 70% higher than non-physician males, and females 250 to 300% higher than non-physician females. That's astounding. 300 to 400 physicians a year, taking their lives. And people not wanting to ask for help because of the stigma that they think goes along with it, and that might hurt their careers.
That's fascinating, because physicians would be the very people you would think would be the ones who were able to deal with it better because of their training or because of...
well, it's the opposite.
It's the opposite.
They're not allowed to, or they think they're not allowed to. And we in medicine and we in healthcare education have to change that climate and change that culture to, like you said earlier, it has to be okay to say, I need a little help
I'm not
here.
okay, yeah. Well, we only have a few minutes left, so I want to touch on a couple of other topics that I think are very important, most notably prevention. We're talking about suicide. We know all the statistics. We know some of what happens and maybe sometimes even why. But what can we do as a healthcare community and also in our personal lives? Because suicide is totally preventable, yes?
It is
It's
preventable. I mean, there are going to be, sometimes you try to do everything you can and a person may still take their lives, but it is largely preventable, yes.
So what can we do in a concrete manner if we notice that somebody that we think needs some help or is starting to go down that slippery slope?
Well, I think as you've discussed earlier, I think we need to acknowledge it. We need to let ourselves have permission to bring it up and to talk about it. If it's in our families, let's call the family together to figure out how can we rally around our family member.
And not in a punitive way, but in a supportive way.
Definitely not in a punitive way, and not in a way that says, toughen up, get in there and fight. There are other people that have it worse than you. That's not what you want to be saying. What you want to be saying is, we notice you seem to be suffering, and we love you, we're concerned about you, we want to help you.
I've noticed that a lot of people do exactly what you just said. They sort of minimize or kind of deflect it. If I say I'm feeling some kind of way, and if I say it to I don't want to say the wrong person, but if I say it to somebody who's not in tune with that, they might say to me something like, "Oh, it's just temporary," or "Oh, I know you. You'll get over it, or you'll get past it, or you just need to sort of power your way through it." And I think that's what most of us tend to do. We tend to power our way through things, and the people that we see who are not like that, we tend to see them in a negative light. They're not go-getters. They're not energetic. They're not. They don't have that whatever that quality is that we look for in people. So I do want to get the message across that it is something that we can prevent or at least educate people about, so that perhaps moving forward we can prevent some things from happening. Are there any hotlines? Are there any places that people can go to aside from calling 911? But any place that people can go to for more information or for more support if they know someone?
And we're going to show those numbers.
Okay.
There are a number of them. 1-800-LifeNet is one, and there are others as well, and we're going to be posting those on the screen so that your viewers can see that.
Okay, very good. So we're going to have trailers at the bottom of the screen as we're talking that are going to have phone numbers that people can call. And when they call, will they get a live human being?
Yes.
Okay.
And not only that, but in I think something like 150 different languages.
Oh, good.
As well as for the hearing impaired. So there's really, one of the things that we talked about prevention before is removing obstacles to care. And this is one of those things. Programs like yours where people can feel empowered and okay enough to talk about these issues, and also pointing people in the right directions to take obstacles out of their way.
Well, I think you've been very helpful. I know that sometimes psychiatry is a bad word, and people tend to think that if you're under the care of a psychiatrist, or you're seeing a psychiatrist or talking to a psychiatrist, that there's some negative connotation to that, and that's totally not true.
That's right.
We should be very encouraged to get help in any way. I always say to people, if you have a toothache, you go to a dentist. If you have a heartache or a psyche ache, you go to a psychiatrist or a therapist.
And we take pride in people that want to better themselves, get more degrees, get a better job. Well, who doesn't want to be a better person, or a healthier or happier person?
That's right. Well, Joe, thank you so much for being a guest on today's show, and I hope that we have shed some light on this very serious topic to our audience. Watch for the trailers across the bottom of the screen. You'll be seeing some numbers that you can call if you feel suicidal or are having suicidal thoughts, or anyone that you know in your family or among your friends. There is help available. We have a good department of psychiatry right here at Downstate Medical Center, and please don't let people suffer alone, and don't let them suffer in silence. Thank you for watching Health Center.